Good morning, everybody, and welcome to the Insight APSAD seminar series again this morning. We'll begin, of course, by acknowledging the traditional custodians of the land in which this presentation takes place and paying respect to elders past, present and emerging. We'd also like to extend that respect to other Aboriginal and Torres Strait Islanders who might be joining us here today and on the web. Eating disorders are common and increasing in prevalence. So today we have Associate Professor Warren Ward. Warren's the Director of the Queensland Eating Disorders Service, and he'll be presenting on treating eating disorders made easy. So his presentation will be looking at all you need to know about defining, classifying, understanding prevalence, causes and mortality and course of eating disorders. So quite a bit in there. Warren, you'll also get a practical guide to engaging, assessing, including criteria for admission and treatment interventions. So the presentation will conclude with an overview of evidence-based treatment strategies for developing and maintaining a therapeutic alliance. So I won't waffle on too much longer because I'm itching to hear this presentation, so I'll allow you to...
Thanks, Rod, for that kind introduction. It sounds ambitious, that blurb, doesn't it? Nice to see you all. Just like to introduce my colleague too, Joe Dalton, who's a CNC who looks after education and training statewide for eating disorders. She helped organise this talk, so thanks, Joe. So, eating disorders are common. They're increasing in prevalence. They're deadly. They're mystifying. I imagine they're quite common and possibly under-recognised in people with addiction problems, because malnutrition can actually cause eating disorders, as I'll explain in the talk. Anorexia in particular has the highest mortality of any mental psychiatric illness, 10 to 20%. And I feel some kinship, I must say, with my alcohol and drug colleagues, because we're sort of working in an area where there's still a bit of stigma, even amongst mental health clinicians. I'm sure you recognise this. And the mortality and morbidity is frightening, and probably the increasing prevalence. So I think we have, and I think there's a lot of misunderstanding about both addiction and eating disorder problems. So I think we've got something in common in the fields we work in. If we look at some of the other very serious mental illnesses, schizophrenia, bipolar disorder and depression, we see that anorexia nervosa is in a league of its own in terms of mortality rates. And we would argue that the resources and training of clinicians should reflect that, but it probably doesn't at this point. A fifth of those deaths in people with anorexia nervosa are due to suicide. It's a very tormenting illness, but 4/5 are due to medical complications. And they're increasing in prevalence eating disorders, and they're common and often undiagnosed. 1 in 20 Australians has an eating disorder, at least. Approximately 15%, what's that, about 1 in 7 or 1 in 8 women will experience an eating disorder during their lifetime. And there have been some really good community epidemiological work done in Australia by Professor Philippa Hay from University of Western Sydney, where they've done telephone and door knock surveys of people in the general community. They did one large survey in 1995 and another one in 2005, and what they found was the prevalence of eating disorder behaviours had doubled in 10 years. Mainly women aged in their 40s to 50s and 30s, binging and purging and not seeking help. The Butterfly Association, which is the peak non-government organisation advocating for people with eating disorders, commissioned Deloitte to do a socio-economic report into the impact of eating disorders in Australia in 2012. And what they reported was that almost 1 million Australians had an eating disorder. That does include binge eating disorder, which is even less diagnosed. At a cost of $69 billion to the economy, and in 2012 there were 1,800 deaths due to eating disorders, 500 males and a bit over 1,300 females, mainly young people. Another report commissioned a couple of years later and launched by the Federal Health Minister Suzanne Ley in 2015, I think this was. But actually the chair of Butterfly is David Murray, who used to be the CEO of the Commonwealth Bank. And they've done a lot of economic modelling and found that early intervention for eating disorders gets the same results at a fifth of the cost to the community. So that idea that we've seen a little bit of and see less of now, where people are told by the GP, "I know you're not sick enough yet," or the emergency department, "Come back when you're lower weight. You're not sick enough to be treated," goes against what this survey showed. And I'm sure you, in your area, you would have the same view. But in cervical cancer, hypertension, heart disease, we don't say wait till you're sicker before you come back, do we? Eating disorders are treatable too, so I'm sort of trying to debunk some of the myths that are out there that they're maybe not treatable. Recovery is possible. About 70% do fully recover after 5 years. Evidence-based treatments are available, but to get better, someone with anorexia or another serious eating disorder needs a lot of help from you, because they turn up to all clinicians in sorts of areas, and they often need help from a range of different people over a period of a couple of years. So your classic case of anorexia nervosa, BMI 14, presenting to an emergency department, would need a few weeks to get medically stabilised, a couple of months to get their nutrition good enough that their brain is functioning again, because it's not widely known that malnutrition really adversely affects the brain, and about a year of evidence-based psychotherapy. So you're looking at a 17-month course of treatment, minimum, for a cure of anorexia. And that often involves GPs, emergency departments, medical wards, mental health wards, community mental health, a whole range of people working together. So I want to just open it up to you a little bit. Because we're being recorded, I'll repeat what you say so it's on the mic. But I wanted to ask you, we've got this, maybe an epidemic of a life-threatening condition in our midst, taking away our youngest and brightest. What are the causes of this deadly illness, do you think?
Post-traumatic stress disorder.
Yeah, so post-traumatic stress disorder, trauma definitely increases the risk of an eating disorder, especially trauma in those first 5 years of life. Again, we've got another parallel here with addiction, in that because fasting does actually help you regulate affect. We know that trauma, causes a whole lot of negative affects, and fasting, exercising, binging, purging, all these things, counting, your calories or on your Fitbit, all these things can actually help you manage affect. So it's no surprise that some people with trauma end up on that eating sort of pathway. I'd say that is about less than half of them, though. About half of people with eating disorders don't have a history of trauma. They have a different etiological pathway, which we'll talk about. But any other thoughts about the sort of things that might lead to
Why do you need media?
The media? Yeah, so the media media is a word that means in between, isn't it? It's between the culture and us, or the message. So any culture where thinness is idealised and where that's magnified through the media, definitely. And I'm going to present a study that actually shows the effect of the media on communities in terms of increasing the risk of eating disorders. That's right. So we've got trauma, media. We still haven't got the biggest risk factor for eating disorders mentioned yet. Any other? Sorry? Bullying. Yeah, bullying, teasing, around 13, 14, 12, that sort of age definitely increases the risk of a whole lot of conditions, including eating disorders. Yeah, again, people find it as a way of controlling, especially if they're bullied about their weight. Yeah, some mental illnesses. Can you think what sort of mental illnesses might make you more likely to develop an eating disorder?
Depression.
Possibly. I'm thinking more OCD, obsessive compulsive disorder.
Perfectionism.
Anxiety, perfectionism, that's right. We still haven't got the biggest risk factor for eating disorders. So if any of you've got daughters, you need to know this one.
Genetics.
Well, gender is a huge risk factor. Genetics is actually a very big risk factor for anorexia. 50 to 80% of the variance in anorexia can be explained by genetics. What do you think it is that's inherited that causes some people to catch anorexia? Some girls rather than others. They probably inherit perfectionism. So it's very biologically heritable, the personality characteristics of obsessionality, perfectionism, conscientiousness, harm avoidance, all that sort of what I sort of call the good girl. Okay, so you've got some that have got a history of trauma, and the others are very perfectionistic, obsessional. They often get very high marks, and they're a big risk for anorexia, that group. That personality style, which is highly inherited, also puts you at risk for OCD, anxiety disorders, but also puts you at high risk of becoming a doctor or a dietitian or a psychologist or an engineer. So that sort of personality leads you into that, to doing well in society often, but certainly increases your risk of anorexia. And we see a lot of that. In our inpatient unit, I usually joke we usually have a full multidisciplinary team amongst the patients. We usually have a medical student, a law student, engineer, a couple of nursing students. And so what that reminds us is that we're not normal, okay? So I'll speak for myself maybe. But those of us who are attracted to these sort of professions and all that study, we've got a certain type of personality that's not like your average personality in the community. And so that's sometimes where these patients are a bit hard to read. They're a bit like us in some ways. They're very intelligent and logical and crazy. Okay. So we still haven't got the biggest risk factor for anorexia. You've got a daughter, you know, say you've had melanoma, you're going to use sunscreen with your daughter, aren't you? Because you've got a risk. But say you've had anorexia in the family, and what's the biggest risk factor for anorexia by far?
Dieting.
Correct. Well done. Okay. So if two teenage girls, if one diets and the other doesn't, her risk is 18 times her peer. Okay. I keep mentioning women, but men do get eating disorders, about 10 to 15%. So dieting. I'll explain what it is. So if you wanted to cause someone to have anorexia, get two doctors to breed, throw in a bit of trauma in the first 5 years of life or some attachment problems. Ideally make them obese so that they're bullied and teased, because obesity is a risk factor for anorexia nervosa. Certainly put them in a culture where thinness is idealised, so Australian culture is pretty good for that, but also American, Korean, Japanese, Indian, Chinese, all those cultures now have the European worshipping the thin ideal. Give them an Instagram account when they're about 5 so they can look at thousands and thousands of images of people and their body shape, and they can start basing their worth on that. And also, if you start talking about your own weight and how unhappy you are with your body, that would help as well. Okay, if you want to create anorexia, give them a bit of stress, but then throw them on a diet, and it's like a powder keg. Now, why does dieting cause anorexia? It's actually very interesting. There's some biological links between dieting and catching anorexia. It's because it causes a thing called starvation syndrome. Now, we know about starvation syndrome thanks to this man. His name is Ancel Keys, Keys. First name Ancel, Ancel. He commissioned the Minnesota Semistarvation study in the 1950s that I didn't learn about at medical school, but we make sure all of our clinicians we train, but also all our patients and their families know about this study. What Ancel Keys did, and he got on the front cover of Time for his study, his seminal Semistarvation study, he got 36 men who were physically and psychologically healthy. They were actually conscientious objectors to being conscripted during the Korean War. And in those days, if you decided you didn't want to be conscripted, you would go to prison. But you did have a third option, which was to volunteer for a medical experiment. And so that's what these 36 fine specimens of American 1950s masculinity signed up for. And Ancel Keys, they volunteered. He put them on rations for 3 months, he and his team, and where they lost 25% of their body weight. Then they were observed for 6 months. Then they were re-nourished. So it was a 12-month study. And the study itself is a really great example of just beautiful, detailed, descriptive study. It's about 2 telephone books thick, the whole study itself. But what he found was, and one of my colleagues and friends is Mark Daglish, who is the director of HADS, and often talk about these very low weight patients who end up in HADS from their addiction problems. And so it's good to know about the physiology, I think, of malnutrition as well as the brain effects. But all these men, can you guess what might have happened to them physically? What happened to their blood pressure? Dropped, yeah. Their heart rates? Dropped. You're on a roll there. Yeah. Their temperature? Dropped. Good, you're getting good at this. Yeah. So all those things reduced because the body is trying to conserve energy if it's not getting enough energy. So all our patients, that's what we see. Also, 100% of them had profound effects on their thinking, emotions and behaviour. Can you guess what sort of effect these men who were normal, remember, after 3 months, 100% of them went crazy, really. I keep using technical terms because I'm a psychiatrist. But what do you think might have happened to their thinking and their behaviour?
Obsessive.
Yes, they all became even more obsessive. These men probably were a bit more conscientious than your average man, but they became obsessive about food. So they thought about food day and night. They started to write recipes and exchange recipes with each other, which was unusual for American men in the 50s. And when their rations came, they sometimes would hoard the food and eat it later. Sometimes later never came, they just kept hoarding it. Hoarding behaviour increased. And when they did eat, they had these rituals. And these rituals are similar to what we see in the eating disorder unit before people are renourished. With anorexia, they would cut their food up into certain shapes, have lots of rules about it, want 2 hours to eat it in complete silence without anyone talking to them, and they'd have all these rules about how they would eat and the order in which they would eat their food. They became extremely obsessional. But the thinking also became obsessional and very fine-grained and rigid, not about food but everything else. So they sort of got this, if you like, brain-starved induced OCD, obsessive compulsive disorder. They really lost their flexibility of thinking, their humour, their ability to go with the flow, and they just had rules and rituals from morning to night. This all reversed when they were renourished, this type of thinking. Many became depressed. We find with our patients that their BMI is below 15, and you'll see this with your clients too, they often have this biological depression that doesn't respond well to antidepressants, but responds well to brain nutrition over several weeks. 3 became suicidal. These were men who were totally psychologically healthy before the study, and 3 were admitted to the local psychiatric unit, and 1 chopped 3 of his fingers off in a self-harm attempt. They were profoundly affected, these men. They became very withdrawn socially, no libido, and so they really were in a bad way. They were renourished. During the renourishment process, many became obsessed about changes in their body shape, and at the end of the study, all were totally returned to normal, except 3 changed their occupation to chef. We tell everybody we know this study, and a lot of the patients we see, they were totally normal, kids of professionals, for example. They decided to go on a diet, do the right thing. It's the right thing to go on a diet. We're all being told to go on diets, aren't we? But some of these kids who've got the genes catch this obsessional thinking, and then it got out of control, and I was measuring how much I was exercising and cutting food groups out. Next thing, they've gone totally crazy. And when we nourish them, their humour and the flexibility of thinking and insight comes back. But drugs don't work, but brain nourishment does. That's the key message I want to really share with you today. Because we sort of think it's psychological, but often it's quite biological. And as we know, dieting is encouraged. We hate fat in our society. There's a lot of stigma about fat and obesity. In a way, we're all made to feel a little bit bad about our bodies and that we could do better. It's an interesting culture we live in. It's been a lot worse since the 80s, 90s. It's getting worse. This is the study I referred to earlier, a very interesting study by a psychiatrist and anthropologist called Carolyn Becker. She wanted to know the effects just of television on a group of Polynesian teenage girls, in this case, and she found an island in Fiji in the 90s that had no television. I don't know how they lived, but apparently they lived on this island without television. She observed eating disorder thoughts and behaviours in this group before and after, and then after television she did surveys of them and observed them for 6 months, and then later, 3 years later. What she found was very disturbing, that just by introducing the wonderful television, eating disorder symptoms increased 5-fold, vomiting to control weight increased from 3% to 15% amongst this group of girls. 74% felt too big or too fat. They didn't feel that before television. And 60% had been dieting, which we now know is a very risky behaviour, in the past month. And the favourite programs included Melrose Place, ER, and Xena the Warrior Princess. So all good quality American television programming. The reason I mention those titles, as well as it being a bit funny to remember them for some of us who are old enough, is that they weren't watching The Biggest Loser. They weren't watching a show that said you must lose weight. They weren't watching undernourished people. They were watching normal American television stars who all have a certain body shape, which only 3% of the population have. Okay, so when they looked at that, they thought, I don't look like that. I need to look like that because I want to be Xena. And even Xena's a bit muscular. We might see her as a good role model, but it's still not your average. Most of our weight and shape is determined by genetics and lifestyle, and it's just not like on TV. If they'd watched gritty British dramas like The Bill, they wouldn't have got eating disorders, but American TV, dangerous. Now that study, even more frighteningly for me, who's got 2 teenage daughters, was before these 5 things were words, new words. Facebook, iPhone, Instagram. Probably the greatest invention of the 21st century, arguably, the front-facing camera, allowing us all to have, in thousands of years when our civilization is visited, they'll find, fortunately, just hundreds of thousands of selfies, and they'll wonder about us, won't they? And Snapchat. Okay, you can see how that might be an etiological factor for the epidemic of eating disorders in young people. For me, it's a bit similar to smoking and lung cancer. Lung cancer is caused by smoking. It's a biologically caused illness. But there were cultural factors that led to an epidemic of smoking. In the 40s and 50s, doctors were recommending to patients that they smoke for their nerves. It was recommended by doctors. Now doctors are recommending people diet, and this is another whole talk, but 90% of diets are ineffective after more than a year, and they're really high risk of causing eating disorders. So we're very anti-dieting professionals internationally who work in the eating disorder community, mainly because it doesn't work to treat obesity for a start, but it also can cause harm. We didn't really know how harmful cigarettes were in the 30s. We don't really know how harmful dieting is in this century. Like many of us do know, but it's not out there in the general professional or general community. Is body image concern an epidemic? Well, Mission Australia, they do a national survey of young Australians every year, an amazing survey. They get up to 19,000 people. Every year in, year out, it's in the top 3 with 26.5%, not being concerned, but being highly concerned, and that's boys and girls, about body image. You can see with the new technology why body image is becoming even more of a concern. I've just noticed young people are more into waxing, working out, and changing their appearance. It's a really huge cultural shift. All right, how do we treat someone? Again, I'm focusing on anorexia, but the treatment's actually the same or similar for all eating disorders, I'll explain. But for the sort of more high-risk patient, it's really 3 steps. And I think of it as treat the heart, stop them having a cardiac arrest, and we're going to talk about how you can predict someone likely to have a cardiac arrest, because they often feel fine. They actually feel great. It's similar to addiction in that there's a lot of positives from being low weight. It gives people a bit of a buzz. Then we treat their brain so that we can actually work with them. Then I would say, treat their mind, help them to deal with feelings in a way that often involves a bit of cultural critique, the psychotherapy. But in that order, it's no good doing psychotherapy with someone with a starved brain. It really is very difficult. Okay, so if your daughter is diagnosed with anorexia at the age of 16, she has a 10% chance of being dead at the age of 26. They're very sobering statistics. And people can feel great and have normal bloods just before sudden death due to arrhythmia. Okay, so the best indicators of imminent cardiac risk within the next few weeks, in other words, they usually die in their sleep and the heart just stops because it's going slower and slower and slower, and then eventually stops. These are the indicators, and these are reflected in our national guideline, the College of Psychiatrists guidelines for when to admit people with anorexia. If their BMI is less than 14, you can't physiologically function for too many months after that. The risks are very high. No, if they haven't eaten at all for several days, think about bringing them in. If their purging's out of control, think about it. But probably more importantly are just the cardiac indicators. They're the ones I would really rest my hat on. If the blood pressure is less than 90 millimeters systolic, which means their heart can't actually, it's trying to conserve energy so much it can't push blood up more than 90 millimeters up to the brain. If they get a postural drop, we always check lying and standing heart rate and blood pressure. That's probably the most important test on anyone with an eating disorder or with malnutrition. if their blood pressure drops by more than 20 millimetres. Check their heart rate. I presume there's some nurses in the audience and medical people. There's usually a nurse handy. Check their heart rate. If it's less than 50 or greater than 120, bring them in. If they have a postural tachycardia from lying to standing of more than 20 beats per minute, we recommend admission. That is probably the most useful test, actually, because often young, fit, exercising people, it's hard to, they don't tend to get the drop in blood pressure, they're more likely to get the postural tachycardia. And if their bloods start to go out, the body will fight very hard to keep all your bloods normal. All these things, potassium, phosphate, magnesium, glucose, you need them to have your heart beating. If they start to go off, you're at risk of a cardiac arrest. And prolonged QT interval, or if they start fainting or getting cardiovascular symptoms like chest pain, palpitations. So that's another important take home, because usually in this case the person is dragged in by their mother. They're saying, I'm fine, I don't need any help. Check their heart rate lying and standing, and then you can start talking to them and the mother about the risks. That usually changes that conversation a bit. So this is my 5-minute medical check. We have an assessment clinic at the Royal, which you're welcome to refer any patients to. They'll see me or my registrar, and I just usually do a quick 3 or 4 minute medical check before we do the hour-long psychiatric assessment. Want to know if they've had any medical or physical problems in the last few weeks, ask about fainting, cardiovascular symptoms, and we just check the heart rate and blood pressure lying and standing. We always ask for GP referrals, actually, and we always ask the GP to do those tests before they're sent. So that way, if their biochemistry's off, we will just tell the GP to send them straight to the emergency department rather than waiting for an appointment with us. So we're big into risk management in the first couple of months of treatment. Now, like you, we often have people who are in denial about the risks of their behaviours, or they're ambivalent about letting them go because they get some benefits from them. And I've noticed when I start talking to people with anorexia about all the risks, their eyes just roll, it all becomes a bit confusing. So I've just found it helpful to draw a little picture for them. So often I say that, especially a patient where I'm really quite concerned about their medical status and they think they're fine, I say, well, as a doctor, this is actually how I see you when you walk in the room, and these are the things I'm looking at, which is what's happening with your heart function, your liver, your brain, your bone marrow, your ovaries, and your bones. And I often say to them, I'm not actually that concerned about your weight. Anorexia is obsessed about weight, but we're more concerned about whether your heart can keep beating with the fuel you're giving it. And so, we have patients who have a bowl of oats and some goji berries for the day. They'll have big rocket salad later for lunch, and they're running 4 hours a day, and they're underweight. The risks are very high of a cardiac arrest. So I draw this and I explain to them what, in terms of the previous slides I've shown you, what we're looking for. It's normal for people to get amenorrhea, for their ovaries to shut down when the BMI goes below about 16, and then they're at really high risk of osteoporosis. This person's not happy because he or she is coming into hospital. It's a she in this case because she got ovaries. But they're all the things we'd be looking for. Any of these would suggest admission. If someone's brain is just so rigid, terrified and panicky, I can't possibly change anything, and they turn to their mother and say, tell him I cannot have anything more to eat. Just that sort of panic about food, it's worrying. If the sodium drops below 125, that's usually a sign of water loading. So people often with anorexia, they might water load to manipulate their weight, but more commonly they're just trying to be pure and just have water because it's healthy and no calories. It's a common thing. I want to make sure we have time for questions, but I think we've been through most of those things. Bone marrow we haven't talked about. Again, when people have malnutrition, they usually have neutropenia. Their white cell count falls below a normal range, and we find this a really useful indicator, often more useful than weight, of malnutrition, and it normalises with several weeks of nutrition. And we would always do a bone mineral density scan if their periods have stopped for 6 months. We try to not kill patients. I've just been on the phone about, I'll tell you about this case because it's maybe a bit more illustrative than this slide. So just had a call from a regional country hospital about someone who was admitted there, with a BMI of 12. I'm not going to say anything identifying about them. They're 40 years old, and this regional hospital has started giving this person nasogastric feeding because they could see that she was really, really malnourished, like extremely underweight. But on their blood tests, within about 3 days, she had 3 abnormalities. Her serum phosphate dropped to very low. You see this in your population too, in HADS. The potassium dropped to below normal range, and the magnesium dropped to below normal range. Would like to venture what's happening there physiologically? It all happened in about day 3, and when I rang today, it's still happening. They can't get their magnesium up to normal. Refeeding syndrome. You see it a lot in people with addiction. You certainly see a lot of it in HADS too. Okay, so anyone who's had severe malnourishment and been underweight for a long time, their intracellular potassium, phosphate, and magnesium will be very low in the cells, particularly in the heart cells. And if you feed them aggressively, and this happened a lot in Africa with kids, you'll kill them because the potassium, phosphate, and magnesium all get sucked up by the Krebs cycle when they try to metabolize that food, and they have a cardiac arrest on day 4. So it's a very important medical condition to know about. This person in this other hospital has got it, and I was concerned the doctors weren't really as concerned as they should be. But I found out ringing them they are. They're trying to give her intravenous magnesium, and she's got diarrhea as well. And I said, you need to ship her to a bigger hospital because she's at risk of dying. So any malnourished person you should see as a high risk of refeeding syndrome, and don't feed them too much. Like, there are recommended amounts of nutrition in our statewide treatment guidelines, 1,500 calories a day, and give them thiamine because they can develop Wernicke's encephalopathy, this group, even without alcohol and drug problems. You know about that condition. And we check their phosphate, magnesium, and potassium every day and replace it if it falls, and especially day 3 to 4. So this can happen in hospital, so that's really important. So the next stage of treatment, once we've got their heart stable, is to get their brain to the point where we can actually have a useful conversation rather than them just arguing about calories. That's hard. It's hard to stop an alcoholic drinking. It's hard to stop an anorexic from not eating. It's a similar sort of use similar skills, really. A lot of education and motivational interviewing. But in our case, it's a bit different because we do use the Mental Health Act, because we know that food to the brain will restore their capacity, and we can do that over a few weeks. But it's very hard to do that, and if they're really sick, we have very controlled regimens really in medical wards now. So we have guidelines now where people are admitted to every hospital in Queensland, and they have a pretty standard protocol, which is nasogastric feeding, 24 hours at a certain rate for the first 7 days, and then they switch to oral food. When we used to feed them orally in medical wards, we'd find they just wouldn't eat, and that poor nurses and staff, not very good at supervising oral meals in a busy medical ward. But if they're sick enough to go to a medical ward, we put them on nasogastric feeds, and their brains are so much better after a week, as well as their hearts. How to assess weight? Look, I don't want to get too obsessional about this, but I think I'll tell you just a bit more about this patient in the regional hospital. The doctor said, as well as having low magnesium, low phosphate, low potassium, which is all very scary, for your heart, in this regional hospital, and developing pedal edema, swelling in her ankles, so it's quite large. But the good news is that last week she's gained 7 kilograms. So my eating sort of colleague knows why that's a concern. So she'd gone up from, in her case, 22. From about 22 kilograms to 29 kilograms in a week. Why am I concerned? Oh, we're trying to put on weight. What's the problem?
Too fast. Or is she really put on the weight, or is she water loading, or is she fighting?
Yeah, all good questions. No, the doctors, she's got edema. So her protein is so low in her body, like people with kwashiorkor, starvation syndrome you see in Africa, that this fluid just leaking out, and she's accumulating fluid. So, and that's putting strain on her heart. She's at risk of dying soon because none of us can put 7 kilograms of fat or muscle on in a week. it's fluid, okay? And she's at risk of going into heart failure. So when you assess weight, when we assess weight, we always take everything else into account, which is what are they actually eating? And in this case, she's been on a nasogastric feed and she's supervised, so we know she's getting the nutrition. There was no reports for pouring it out. So we don't accuse the patient in this case, and medically she's going off in a terrible way. So we know she's getting worse, actually, even though weight's going up. Okay, so weight's a very rough indicator of progress. Assess the weight every month rather than every day. That's a bit of an exaggeration, but really don't read too much into it. Look at what's happening with the bone marrow. Are neutrophils coming back into play? Is the blood pressure improving? Is the brain improving? They're better indicators than weight. We use a thing in our unit called BMI banding. So have you all know what a BMI is? Anyone not know? Yeah. So this particular BMI banding is where we actually don't know the weight of our patients, neither do they, in kilograms. We only know it if they've gone up what's called a BMI band, which means they've been in a different BMI level twice, either up or down. And so all our patients only have about 4 weight changes during a 8-week admission. Because when we used to say, oh, you've gone down 300 grams, so we're going to stop your leave, and is there anything you want to tell us? That's really bad treatment. It happens a lot. It probably just means they had a bowel motion. Okay, really? And all our weight fluctuates by about 1 or 2 kilograms every day. It means nothing. It's about fluid shifts. But we want to know if a BMI band is about 3 kilograms, so that's a definite change in weight. Just to illustrate that idea of BMI banding, this patient's been monitored for 9 weeks in a medical ward, and that's been her progress if we look at it in kilograms. So the treatment routine will say, we're getting there. Okay. If we measured it in BMI, not BMI band, just BMI, we'd see, well, maybe we're getting there, but actually, gee, her weight's low, isn't it? The BMI lets you actually know how low her weight is. That's almost not consistent with life. She's a very sick person. If we do it in BMI band, 9 weeks of feeding, this is the progress. Nothing. We know people should go up with BMI in 3 weeks. So there's something going wrong. She's actually hiding the food in this case. So we find that helpful to know real progress in weight rather than just minuscule changes. So for someone to increase their weight, if you're treating them as an outpatient or an inpatient, first thing is you need to give them advice about how much nutrition they need to increase their weight. And it's actually hard to increase your weight. Some of you might disagree with that, but if you're underweight, it's very hard to increase your weight. If you're overweight, it's hard to lose weight. Weight changes are difficult to achieve. And if you want someone with anorexia who's got a BMI of 13 to get up to a BMI of 17, which is what we usually recommend before they're discharged to community treatment, they have to eat twice as much as you because you're maintaining your weight, they're increasing their weight. Putting someone with anorexia on a normal diet will never ever get them better. They'll just stay low weight. Remember, you have to give them what they need for maintenance plus increase. It's a lot of nutrition. And so we use a lot of high energy supplements rather than food because it's too much food for most people to bear. So we often add things like Ensure, Resource to make it easier. So you have to prescribe the right amount. So it's all of our patients within a week would be on 3,000 calories, wouldn't they? Yeah, in hospital. So that's quite a bit, Most of us are probably sitting on 2,500. And that would lead normally to a weight gain of about 0.5 to 1 kilogram. So don't blame the patient for not putting on weight if you're not giving them enough nutrition, and you need to have realistic goals. So it'd be reasonable to expect in 4 weeks that they put on 2 kilograms, but don't read too much into week by week. So with our patients, if someone's really low weight but not low enough for admission, say BMI 15, I might say to them, if you can't gain 2 kilograms in the next 4 or 5 weeks, we're going to have to bring you into a higher level of care because we can't keep you at this low weight. With inpatients, we base leave, and leave is usually trials to eat outside the hospital unsupervised to make sure they can feed themselves before they're discharged. We don't just feed people and discharge them. We feed them, give them practice at feeding themselves, like you might give people practice at abstinence in challenging situations, and then go to community treatment. But we want leave to be based on real weight gain. It's hard to give psychotherapy to anyone whose BMI is less than 16 or 17, so we generally recommend that before discharge. Otherwise, you just, I actually see the admission a bit like detox, and the psychotherapy is like rehab, if that makes sense, in terms of you've got to get their brain sort of befuddled first. This is not really, the psychotherapy of eating disorders is quite complex and it's a specialised area, so I'm not going to go into detail about how to do psychotherapy, but I will talk about some non-specific things where you can use skills you already have in your sector that are helpful. There are now 3 manualised evidence-based treatments for anorexia. There weren't when I started in this field 13 years ago, there were none. So they are CBTE, SSCM, Specialist Supportive Clinical Management, and a new one called MANTRA, Maudsley Anorexia Nervosa Treatment for Adults. They all have manuals. Our staff are all trained in them. We do, there are other training opportunities, and they all involve at least 20 weeks of hourly sessions. The most important thing for CBTE, and in fact all the treatments, is to reinstitute. We do a lot of psychoeducation to explain to people the effects of starvation syndrome, and to reinstitute the rule of 3s with every patient. This is the same with binge eating disorder too, because the most common cause of binge eating disorder is people's dieting. They restrict and then they lose control and binge. Same with bulimia, they restrict, they lose control and binge, then they purge, then they try to diet again the next day. So dieting causes all 3. If you've got the anorexia gene, you'll be one of those weird people who can just not binge. But most people end up with increasing weight when they go on diets. So we do a formulation with the patient, trying to understand what's led them to being stuck in this pattern. But the rule of 3s is 3 meals, 3 snacks, and no more than 3 hours without food, except when you're sleeping. Because your brain needs that, otherwise it'll go into some sort of starvation syndrome. There's a lot more to the treatment, and there is a treatment manual, which I think is in one of these slides, which we can recommend to you. All my patients with bulimia and binge eating disorder get shown this diagram, that if you restrict or diet, it's whether you're a dog, a cat, a rat, or a human, all the studies show if you starve animals, they will binge, lose control. And a lot of people with anorexia binge as well. And then a lot of people purge, either by exercise or vomiting, or laxatives. And then they try and restrict again. They could try and be good. So we've had a lot of patients we've seen been coming for 20 years. They've been doing this every day, trying to be good. Next time it'll be different. And once we explain this, and then I usually draw a diagram that shows with binging, studies have shown if you try to stop binging through willpower, that has a 0% effectiveness rate. And they go, yeah, I know, I've tried it. And if you try to stop purging, 0% effectiveness rate. But if you try and stop restricting and actually eat 3 meals and 3 snacks a day, 70% cure rate for bulimia nervosa and binge eating disorder. But that's sort of hard to do, and it requires a leap of faith for them. They worry about they'll put on more weight. But CBTE really and SSCM both involve 6 months of coaching to encourage people to try that experiment, and often they find they don't binge, their weight stabilises, the obsessive thinking about food and weight, the self-loathing disappears, and they get on with other things in life. It's wonderful to see. If you're interested in specialising in this area, the book on the left, Cognitive Behaviour Therapy and Eating Disorders, is a very practical manual. It's the CBTE manual, and it's really easy to read and apply if you've got mental health skills. And there's also a self-help book, Overcoming Binge Eating, written by Professor Christopher Byrne from Oxford University, who developed CBTE, and there have been multiple studies all around the world on this now. So that's another option, is to ask them to read that book, follow the exercises, you read it too. I learned how to treat bulimia nervosa and binge eating disorder from reading that self-help book. It's really well laid out. And if you've read one book and you wanted to start treating some people, I'd recommend it. SSCM was actually a control treatment that was used in a study in comparing it to CBTE, and they found a lot of patients surprisingly got better, despite it being a control group. But it really just involves common sense, intensive 6-monthly support, again 20 sessions, where you focus on education, reinstituting normal eating, support with the symptoms, but also helping with emotions and things in life as well, so it's flexible in that regard. It's the sort of treatment that an eating disorder specialist would use if they didn't have any manual. Now, this slide might be of interest to you because you have skills in these psychotherapies, many of them. Some people say, look, they're not ready for formal psychotherapy, or they might be low weight, and they're actually quite hostile to your efforts to help them or frightened by it. And important, this is how you get the person back to the second appointment, because therapeutic engagement is really challenging and important with this patient group. So motivational interviewing is extremely helpful. And so the way it would go would be, can you tell me all the good things about dieting and being low weight? That's how I might start motivational interviewing. Are there any things that are not so good about it? We list both of them, reflect them back to the person, what you've told me, blah, 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 blah. Where does that leave you? So it's really useful. I find it opens up a space of collaboration and looking at things. As I mentioned, educate about binge purge cycles and starvation syndrome. We find a narrative therapy approach helpful, especially one particular aspect of narrative therapy, which again is used, I understand, with alcohol dependence and other addiction disorders. We separate the anorexia from the person. And so often in our first assessment session, we'd say something like, from what you've told me, it almost sounds like there's these two different parts of you at war with each other. On the one hand, there's this thing that we call anorexia that is obsessed with numbers, obsessed with your thigh gap, with the scale, with your clothes size, and it's the one that is arguing with your mother all the time about what you eat. It's freaking out if someone has a birthday at work and there's a cake. Your friends call you for pizza and you think about what lies you can make up so you don't have to go. That's anorexia. Okay, we see it all the time. But we also see you, this healthy part of you that's come along today, that you said you want this committee in your head to stop, you want a normal relation with food again, you want to stop fighting with your husband. We'd like to make an alliance with that part of you to help you with this part, which we understand is bigger than the healthy part of life. We want to help that grow. So patients love that. They really feel they're empathised with because you're acknowledging the two different parts of them. And we see, we get a lot of our training now from people who've recovered, and they tell us that part's always there, and they appreciate when people acknowledge it's there, even though they can't voice it sometimes. Enlisting the family is very helpful. We bring the family in real close, and we don't blame the family. We empathise with their plight and have them involved in the decisions. We do a lot of behavioural contingencies, especially around safety. Someone walking around with low blood pressure is not negotiable for us. We would use the Mental Health Act if we have to bring them into hospital. We use a lot of team discussion to deal with the intense countertransferences. So, because anorexia, as we explained to the parents, if it is a separate entity, it uses emotional blackmail to make you feel bad for doing the right thing. It really uses a lot of that emotional blackmail. So we use the team to get that wise mind about what's the best decision here. And we try and shift concrete, fear-based amygdala thinking, as I call it, to metaphorical, big-picture thinking. Often these people are really like rabbits in the headlights, and we try and often think of just pulling the lens back, thinking, what's the big picture here? So the patient's saying, I cannot eat rice. I've never eaten rice in my life. And so I just think, well, what are we trying to do here? We're trying to get a heart better. We'll find another way. Other things to consider, get the primary diagnosis right. People with low weight don't always have anorexia. They could have an addiction. We see, by the way, quite a few people with NSAID abuse, non-steroidal anti-inflammatories, where they've been diagnosed with anorexia, but they're actually abusing Nurofen Plus and a lot of other things. And often they have, we've seen a few cases where they've actually got ulcers in their stomach and their duodenum, and they've been misdiagnosed with anorexia. So they often have addiction problems, depression, conversion disorder, autism. We see a whole lot of things that manifest with low weight, but often they still get the starvation syndrome that needs to be addressed. We don't negotiate with the terrorist, so with anorexia, we just liaise with the person. Team decisions, countertransference, we use the Mental Health Act. We try to learn from people who've recovered, like I know your sector does as well. And if they're under 18, the most effective treatment is mostly family therapy, FBT as we know it, rather than individual therapy. So that's important to know too. Okay, this is us. We're the Queensland Eating Disorder Service. We're based in Finney Road, Indooroopilly, but we also have another centre at Windsor. We sort of come under the Royal, but we provide really three things: consultation, training and treatment. So our consultation services, we have an intake person you can call, or patients can call our CNC in business hours and we'll point you in the right direction. We have an outpatient consultation clinic. We go to wards and visit wards or video conference into wards around the state. And we're also helping other services develop their services to be able to better meet the needs of people with eating disorders. We have training, like today. We have Joe's in charge of training. We have, like you, we have specific training activities where we can bespoke them to your needs. And treatment, we have 5 adult inpatient beds at the Royal, but there's always a bit of a waiting list for those. People who don't get better with our consultation service around the state, we would transfer them to the Royal Brisbane beds. We have an excellent day program that's only been running for 18 months, but patients are saying it's the best thing they've ever done. So it's a 4-day a week, goes for 8 weeks, it's a closed group, where they not only learn how to recover from their eating disorder, there's a lot of stuff about affect regulation, dealing with trauma, and we have recovered people, we have pet dogs, we have a garden. It's a really nice community setting, and it's very intensive though, and that's going really well. And we have evidence-based outpatient treatment, CBTE and SSCM. Unfortunately, we have a 3 to 4 month waiting list at the moment. There's a few useful resources. Probably the one I'd recommend is you can Google QEDS now, and our site will come up, and that has access to our referral form, our admission guidelines, and various other things. And the Butterfly Foundation and the NEDC, National Eating Disorders Collaboration, has a lot of nice, interesting fact sheets you can give patients and their families, or for clinicians as well. And they have a help chat line, which a lot of patients like to use. The National Agenda for Eating Disorders has just been released, and that's sort of an aspirational document that's just come out about where we go to in the future. But thanks for your attention. I've left 1 minute for questions.
Thank you very much. We did have some questions.
Yes.
We have a couple of questions online. One person is just asking, what about using vitamin supplements to achieve a balanced diet? Is that good or bad, especially in the longer term?
So everyone heard the question? Yeah. So the main nutritional deficiency all these patients have is energy. And so we do get patients where they're trying to use superfoods or vitamins or minerals, but actually their main deficiency is energy. And so to get better from a low weight eating disorder, you either need high energy supplements or one of these 4 foods: potatoes, rice, bread or pasta. It's very hard to get better with filling, and they need thiamine. That's really important, B1. The other vitamins and minerals, they will get in a good balanced diet, but they're often obsessed with vitamins and they're terribly lacking in energy and fuel for their heart.
The second question was asking if someone has been in recovery from anorexia for several years and is eating well and maintaining a good BMI, does this mean anorexia might have gone, or is it always a risk? Is there always a risk of coming back?
Yes, so some of our colleagues have actually recovered to be better to answer this. But yeah, no, people can be totally cured and fully recovered just as they can from the conditions you treat. But most of them are wary and realise they could have a lapse if they're under stress. So there's certainly people who recover and never have another episode for decades. But I think the ones who do well realise it could be lurking there as a coping strategy if they come under stress. And recovery shouldn't be based on just weight and eating behaviour, but what's happening between their ears. I always say, what's happening inside there at meal times? And if they say, actually, I'm pretty relaxed about food now, that's good. But if they say, look, it's still hard every meal. It's good to know what's happening inside.
3 questions open to the room now.
We had a client recently who'd been investigated for 10 years for vomiting, and it turned out to be cannabis hyperemesis syndrome. Do you come across that?
Yes, we do. So, yeah, we do come across cannabis hyperemesis syndrome, and I'm just thinking of one patient. We end up admitting her to our unit several times because it was just the easiest way to treat it. She not only had that, but she had this sort of conditioned response after the cannabis had all worn off, where just any sort of food made her vomit. And it wasn't really anorexia or an eating disorder, but she had intractable conditioned vomiting, if you like. These treatment principles that we use in our unit did work very well with her. So I think that's a good question.
Warren, are stimulants a common factor? Do you get a lot of people who'd have a cup of coffee and a cigarette rather than a meal?
Yes, or Diet Coke. Yeah, is popular. So yeah, I think well, we sort of have two groups of patients: the good girls who don't drink or smoke, just exercise and have goji berries and kale, and then we have the sort of people with got the traumatic history or often multi-drug use. But yeah, they often use Coke and caffeinated drinks to suppress appetite. Yeah, and we see people with sort of I guess the more serious stimulants like ice and speed, methamphetamine, who end up catching anorexia as well. But with a bit of nutrition, you can often get on top of that, and their biggest problem is the addiction.